Okay, now I want to take a few minutes to discuss the circle of Willis in a little bit more detail. This looks much more complex than it actually is. So let's break it down so you can understand how the anterior and posterior circulations anastomose. So coming up the spinal cord, we have these vertebral arteries, which will give rise to the basilar artery. Now off the basilar artery, we have the anterior inferior cerebellar artery, we have the superior cerebellar artery, and then we have the posterior cerebral artery. Now at the same time, we have the internal carotid artery, and that gives rise to the MCA, or middle cerebral artery, as well as anterior cerebral artery. And then we have a couple anastomoses here. Connecting the MCA to the PCA is the posterior communicating artery, and connecting both ACAs is the anterior communicating artery. And when you look at this, you see this circle that's formed, and that is the circle of Willis. Now, in the middle of the circle of Willis is what structure? That structure is the optic chiasm. Cranial nerve 3 is also in very close proximity to the PCA. Therefore, you can have a third nerve palsy by virtue of mass effect. Now that we've discussed that, let's continue to look at how the major blood vessels supply oxygen to the brain. The ACA, anterior cerebral artery, provides blood supply to the medial surface of the brain. You can see an example of that here. The MCA supplies the lateral zones of the brain, and it is split into superior and inferior divisions. The PCA provides blood to the posterior and inferior parts of the brain. Now, there are watershed zones, and these are the areas that are most susceptible to hypoperfusion, and they occur between the ACA and MCA, and then again between the MCA and the PCA. The ACA-MCA junction mediates the proximal arm and leg areas of the motor homunculus. You should remember that. Thus, an infarct here produces a man-in-the-barrel syndrome, where these patients are unable to walk because their arms dangle and their hips are weak. The ACA-MCA junction mediates the proximal arm and leg area of the motor homunculus. That's something you should remember from earlier in these lectures. So an infarct here produces a man-in-the-barrel syndrome. Man-in-the-barrel syndrome basically is where these patients are able to walk, but their arms dangle and their hips are weak. The MCA-PCA junction mediates the occipital lobe, which we have an example of here. Thus, infarcts here can produce visual agnosias and cortical blindness. Visual agnosia refers to the brain's inability to recognize common objects, even though the visual stimulus is normally received. Right, so the eyes don't have a problem. You're able to actually get the information to your brain. However, your brain then has problems identifying what is happening. A very specific agnosia that you may encounter in popular media or perhaps on a question is prosopagnosia. This is the inability to recognize faces, and the famous neurologist Oliver Sacks actually suffers from this. This is the guy who wrote that book, The Man Who Mistook His Wife for a Hat. The brain receives blood from the anterior cerebral artery, the middle cerebral artery, and the posterior cerebral artery, as we've just discussed. And it is very important to know how these three main arteries supply regions of the cortex. Now, a patient comes into your office and is diagnosed with a stroke. Upon your physical examination, you note that there are serious motor deficits in the lower extremities. The results of the MRI show a cortical lesion. Which blood vessel is likely affected by the stroke? The answer here is the anterior cerebral artery, or ACA. Now, because they told you that it is a cortical lesion, you should be thinking about these three major blood suppliers to the cortex, the ACA, the MCA, and the PCA. Now, the key to answering this question, once you've thought about that, is looking at the homunculus. And when you look at it, it becomes clear that the areas that supply the leg is the ACA. Remember, a way to remember this, because you're not going to have the homunculus with you on the test, obviously, is to remember that the homunculus is basically an upside down person. So if you just think about a stick figure that's upside down along the curvature of the brain, you can remember the legs are more medial, being supplied by the ACA. The arms and the face are more lateral, being supplied by the MCA. The perfusion pressure of the brain is a critically important physiological measure. This is the blood pressure that occurs within the vasculature of the brain. What is the main factor influencing the perfusion pressure of the brain? The answer here is the partial pressure of CO2. However, perfusion pressure can also be driven by oxygen when hypoxia is very severe. The pressure is kept in a very narrow range, typically around 70 to 90 millimeters of mercury, because if it drops low, then the brain becomes ischemic, and if it rises high, then the intracranial pressure goes up, which can lead to hemorrhage as well as hernias. In the graph on the right, we see the response of the cerebral vasculature to CO2 in states of normal tension. As CO2 goes up, there is vasodilation to increase blood flow. Likewise, when CO2 goes down, there is vasoconstriction and reduced blood flow. These changes are not observed in severe hypotension, however. Now on the left, you see that in a wide range of oxygen states, there is no change in cerebral blood flow. Only when PO2 drops below 50, meaning your O2 sat on the monitor would be below 90%, that's when hypoxemia starts to affect the brain and cause vasodilation, which increases the cerebral blood flow. It is important to understand this homeostatic mechanism that works to keep the blood pressure of the brain at an optimal level. So in summary, you can think that CO2 is much more dynamic and is much more important in terms of regulating cerebral blood flow, whereas O2 can have a variety of pressures that lead to no changes in cerebral blood flow, but of course, at a state of hypoxemia, which would be below 90% on an O2 sat, the cerebral blood flow would increase to get more oxygen to the brain. Alright everybody, time for a flash quiz. I don't know why, every time I see this I just keep thinking flash mob, but obviously that can't happen. Okay, what is the significance of watershed zones? Where do they occur in the cortical circulation? Watershed zones are those areas of the brain most susceptible to hypoperfusion, and they occur between the ACA and MCA, and then again between the MCA and the PCA. Okay, now let's talk about the effects of strokes in various regions of the brain. You've got a great table in the book that's organized by anatomical location. Each important vessel is listed on the left, with detail about the effects of a stroke listed there on the right. However, you should keep in mind that test questions will be much more likely to give you the symptoms, and then you will need to sort those into one or multiple anatomic regions, just like your patients will need you to do in the future. So let's start with the anterior circulation. The MCA, as we've discussed, supplies the lateral surface of the brain. So you should expect that the motor and sensory cortices will be affected, along with Wernicke and Broca's area. Now, this will give you contralateral paralysis, numbness in the upper limb and face, and possibly hemineglect. The ACA, right, anterior cerebral artery, is much more medial, and so you should see effects on the motor and sensory cortices that supply the lower limb. Last on the anterior circulation is the lateral striate artery. We haven't mentioned this one before, but actually it's really critical. The lateral striate is a smaller branch of the MCA. Importantly, it is a common location for lacunar strokes. Now, lacunar infarcts are infarcts that occur secondary to long-term hypertension. Because this vessel supplies a striatum, an internal capsule, you can have severe hemiparesis and hemiplegia. It is noteworthy that lacunar strokes can occur in other deep brain structures as well. And with most of the things we've discussed, where it occurs will determine the symptoms. Now we'll move on to the posterior circulation, where we encounter the medial and lateral medullary syndromes. The medial medullary syndrome is caused by a lesion in the anterior spinal artery. This runs down medially and ventrally. Infarction of the ACA affects the corticospinal tracts before they decussate in the medullary pyramids. It also affects the medial lemniscus as it travels from the spinal cord to the thalamus. Lastly, it affects cranial nerve 12. So what are the symptoms you would expect with this type of lesion? Well, you would get a contralateral hemiparesis, you'd have impaired contralateral proprioception, and an ipsilateral paralysis of the tongue. Now keep in mind that the tongue deviates to the side of the lesion. This can be extremely helpful when you're trying to localize the lesion to a particular hemisphere on a question. Strokes in the posterior inferior cerebellar artery, or PICA, are known as either Wallenberg syndrome or lateral medullary syndrome. They are typically caused by a proximal vertebral artery occlusion. Now, many nuclei are affected, as you can see here. This includes the spinothalamic tract, the spinal trigeminal nucleus, the nucleus solitarius and ambiguous of the vagal nerve, the descending sympathetic tracts, and the inferior cerebellar peduncle. Now, what would you expect if all of these different nuclei are lesioned? Well, you'd get a lot of things. So with the vestibular nuclei, you'd see vertigo, vomiting, nystagmus. With the spinothalamic tract, we know that this is important for pain and temperature. Importantly, it will be on the contralateral side. On the spinal trigeminal nucleus, again, we know it's important for pain and temperature. However, this time it's on the face and it's ipsilateral. The nucleus solitarius is important for the gag reflex, so you'll have decreased gag reflex. While because of the sympathetic tract involvement, you will get Horner syndrome. With the cerebellar peduncle, we know that the cerebellum is important for motion and movement, and so ataxia makes sense. And lastly, the nucleus ambiguus, you would get hoarseness. This last clue, hoarseness, is actually something that you should really look out for, because if you see that, you have a very good clue that you're probably dealing with Wallenberg syndrome or lateral medullary syndrome. The anterior inferior cerebellar artery, or AICA, right, A-I-C-A, also supplies many territories, and strokes there cause many symptoms. Here it is on the diagram. Areas affected include the vestibular nucleus, the spinothalamic tract, the dorsal-cochlear nucleus, cranial nerve 7 and 8, and the middle cerebellar peduncle, part of the cerebellar hemisphere. Here I'm just listing the main ones. So what symptoms would you expect from these lesions? So again, with the vestibular nerve and nucleus, you can expect this triad: vomiting, vertigo, and nystagmus. Cranial nerve 7, the facial nerve, you can expect facial paralysis, reduced salivation, lacrimation, and taste from the anterior 2/3 of the tongue, as well as an absent corneal reflex. This is actually kind of an important point, because many times when we think of cranial nerve 7, we restrict it to its impact on the tongue and taste and its involvement in the face. But the corneal reflex is actually a very good test for the cranial nerve 7, and so you should try to remember that. Then with the spinothalamic tract, of course, this is important for pain and temperature, so we'll have those losses. And then with the middle cerebellar peduncle and cerebral hemisphere, again, we know the cerebellum's role in movement and coordinating movement, so we can expect ataxia. Again, with all of these, it's really just important to remember what is this region normally doing. And then if you figure out that there's a lesion there, you can just subtract that from normal function. And so lesion will lead to whatever that region normally does not functioning properly anymore. It's a pretty simple concept. For step 1, the PCA is relatively simple. It goes to the occipital lobe, so you would have loss of vision, and that would happen on the contralateral side. Technically, it would be a hemianopsia, and importantly, you would have macular sparing. Lastly, a stroke in the basilar artery is very, very scary. You can tell this is a pretty important artery. It's pretty big. And this stroke leads to locked-in syndrome. It will take out the pons, the medulla, the lower midbrain, the corticospinal tract, and the corticobulbar tracts, as well as the PPRF. And that's a lot, and it's no wonder then that a lesion there leads to locked-in syndrome. And this name is precisely what it implies. The patient is unable to move. It's not a coma, however, because they retain consciousness and they can communicate through blinking. Now, why is it that blinking is spared when all of these other things are impaired? Well, it's because the upper part of the midbrain is important for blinking. That's where the nuclei that control ocular movements are. And so, obviously, that region is spared, and thus you have sparing of ocular movements. Lastly, we will briefly discuss the two communicating arteries, the anterior communicating artery and the posterior communicating artery. Now, it is less likely that you would get an ischemic stroke in these arteries. Now, why do you think that is? Well, the whole point of this circle of Willis is that it provides redundant circulation. So if part of this artery is blocked, you will still get circulation from the other side. And that's the whole point of having this system. So in this situation, you'll normally have Berry aneurysms instead of ischemic strokes. In the anterior communicating artery, you will get visual defects. whereas in the posterior communicating artery, you will get a third nerve palsy. Now, what is the common symptom of a third nerve palsy? Well, in this situation, you have an eye that goes down and out. Although I don't know if he would be smiling if he has a cranial nerve palsy, but whatever. Alright people, time for a flash quiz. Where are the effects of strokes of the MCA and the ACA felt? This leads us right back to our homunculus. An MCA would impair the face and upper limbs, while the ACA impairs the lower limbs. As we just mentioned, Barry aneurysms are very common at the Circle of Willis. This is an example of a Barry aneurysm here. About 30% of Barry aneurysms occur at the anterior communicating artery, while 25% of them occur at the posterior communicating artery. Lastly, 20% occur at the middle cerebral artery. Barry aneurysms are prone to rupture, which can lead to subarachnoid hemorrhage. Risk factors for aneurysmal rupture include hypertension, smoking, advanced age, and people with adult polycystic kidney disease, ADPKD. There are also two connective tissue disorders that were discussed in biochemistry that lead to increased risk of developing aneurysms. I'll give you a second to think about it. The disorders are Ehlers-Danlos syndrome and Marfan syndrome. Both affect connective tissue, which is obviously an important part of the integrity of blood vessels. Charcot-Bouchard microaneurysms are another type of aneurysm occurring in the lenticulostriate arteries to the basal ganglia and thalamus. When these aneurysms rupture due to chronic hypertension, a hemorrhagic stroke ensues. Central post-stroke pain syndrome is a common cause of central pain. It occurs due to thalamic lesions and usually results from a stroke in this region. It is a difficult syndrome to diagnose because there are other causes of pain that have to be ruled out, such as gout, arthritis, DVT, and musculoskeletal injury. Now, the pain that you get can be either spontaneous or it can be evoked. One way to look out for this on the test is to look for a patient who has had a stroke a few months earlier and is now complaining of pain on the contralateral side to the side where he initially had the stroke. This patient might also complain of sensory changes in the region that also has the pain.